Welcome to this How tutorial on diabetes in racial and ethnic minorities. I'm Dr. Paul Doghramji, family physician from Collegeville Family Practice in Collegeville, Pennsylvania. This program is jointly sponsored by Albert Einstein College of Medicine and Montefiore Medical Center and Asante Communications, and made possible by an educational grant from Lilly USA. First, some overall general considerations. Now, one of the many issues that diabetics face, there are three major components of pharmacologic treatment to significantly improve outcome in their health. Number one, of course, most important, is glycemic control. And here we're defining it with an A1C below 7. The second is lipid lowering. We want to have their LDLs below 100, but preferably below 70 milligrams per deciliter if there's cardiovascular disease. And third, management of blood pressure, management of hypertension. We want to get our diabetic patients to have their blood pressures below 130/80. Now let's talk first about ethnically related risks. African Americans, Latinos are at higher risk for insulin resistance and diabetes. As one becomes an adult as a Latino and African American, there can be between a 40 to 50% chance that they will develop diabetes. This is a little bit higher in Latinos and African Americans. It could be even greater than 50% for Latino women. Hyperlipidemia, abdominal adiposity, a much bigger problem in those that are African American and Latinos. Hypertension, not only is it in higher amounts in these ethnic minorities, but we're also not doing a good job controlling their blood pressures. They can be 2 to 3 times worse in their control in private practice and primary care. Renal vascular disease is also an important consideration with these patients with diabetes. And finally, something you may not think about, which is sleep apnea. Obstructive sleep apnea is rising dramatically in amounts in these patients that have diabetes, but especially in African Americans and in Latinos. Not just the ones that are obese, but especially those that have metabolic syndrome. So when patients come to you that have diabetes, especially diabetes with metabolic syndrome, let's make sure that they are screened for the possibility of obstructive sleep apnea by asking them, do you snore and are you drowsy? What we find, and we'll touch on this a little bit later on, is that if we identify these patients and treat them who have obstructive sleep apnea, not only do their tiredness improve, but they can improve with their cardiovascular parameters like blood pressure, lipids, and even diabetes. We all know that lifestyle intervention is the cornerstone, the most crucial thing in these patients with diabetes. However, it can be very difficult and very challenging. Nonetheless, weight loss. We have to talk about this with our patients, but please set realistic goals for them. We should tell them that only about a 5 to 10% of weight loss can make a significant difference in their diabetic parameters. Certainly, you have to tell them what that is. For example, a 200-pound person may need to lose about 10 to 20 pounds, and over a period of 3 or 4 months or so, this can be very palatable and doable. Next is exercise. This can be very difficult, especially if they have other comorbidities like arthritis or other issues like diabetic peripheral neuropathy. But nonetheless, any increase in physical activity, let's not call it exercise, let's just call it physical activity. Every little bit counts. But try to set specific targets for them, realistic targets. Let's say about 150 minutes per week would be a good idea. That only averages out to a little bit over 20 minutes per day. We'll try to suggest that it be moderate intensity exercise with a target heart rate of around 50 to 70% of predicted maximum. Now, in those in whom the health and situation allows, resistant training 3 times a week can be great for them. But again, let's get these people to be more active and set reasonable goals for them. Dietary intervention. Please be very sensitive to their cultural issues and also their socioeconomic issues. When you talk to them about diet, you should ask them what kind of dietary habits that they have. But it's also a very good idea, if you have one, to have a dietitian that is geared to their ethnic situations. So when you refer patients to a dietitian to go over what kind of dietary habits that they have and what they can change, they have to be very sensitive to their cultural and ethnic needs. Follow-up, follow-up, follow-up. What we find in these patients is that the more we have touches with them, the more often that we have interventions with them, they do much better. And we're not just talking about the physician or physician assistant or nurse practitioner, but also the nurses in the office, medical assistants, the front office who can call and have a reminder for them. But also keep in mind dietitian. It's a great idea to have an initial dietary consultation with all diabetics, and then on occasion, they may need to have a touch-up consultation. Sleep apnea, as I said earlier, is a significant issue for all diabetics, all those with metabolic syndrome, but especially with Latinos, especially since they have a lot more diabetes than non-Hispanic whites. And diabetes itself, of course, is strongly associated with obstructive sleep apnea, and even so with metabolic syndrome. And we've also seen that when we identify obstructive sleep apnea and we treat it appropriately, cardiovascular parameters can improve like blood lipid profile and blood pressure, and even left ventricular systolic function. We've talked a lot about lifestyle, but of course, the easiest way for patients to lower their hemoglobin A1C to get their diabetes to goal is through medications. Now, A1Cs in African Americans and Latinos, they tend to run a little bit higher in relation to fasting plasma glucose than it does in Caucasians, which may affect your treatment decisions and medications. But nonetheless, medications are the easiest way to get their A1Cs to goal. Now, A1C should be measured typically every 3 months, especially in those who are difficult to control and those whose therapy is changing. It's a good idea to ask them to do their A1Cs before they come into their visit, so you have an opportunity to discuss their lab values, maybe even print them out and give it to them so they can have it for their records to go over. Twice a year is okay in those that are stable and at goal. Twice a year A1Cs for those who are stable. Now, for economically deprived patients with limited language skills, you have to be sensitive to this whole issue between the many names a medication can have, the generic versus brand name. It can be very confusing. So try to keep things regular and try to keep things standard. For example, use metformin instead of some of the other brand names that they have, or use glimepiride, or these kinds of names to keep them standard, not to confuse them. It's also a great idea after every visit, especially since they may have 2, 3, or 4 medications that they're taking. Print out their medication list and give it to them, and they may even want to bring them in with them the next time if any changes have occurred by any other medical providers. Home testing. Now, we all know that home testing is required for patients on insulin therapy. But as far as those that are on oral therapy, it's not necessary. It may be a good idea for those who want real-time answers on a weekly or daily basis, but still, it's very important for those who are taking insulin. And as far as how to get these patients trained, please be sensitive to their language abilities, their socioeconomic and educational abilities. Let's make sure that we train them, that we retrain them, and we ensure that they're using it properly by occasionally having them bring their meters to our office and seeing how they're using it. Lipid modification, another important, crucial goal of pharmacotherapy for our diabetics. Now, as an adjunct to diet, of course, statin therapy, for example, simvastatin 40 milligrams a day or atorvastatin 20 milligrams a day, reduces cardiovascular events in all patients with diabetes, including those without dyslipidemia. Now, niacin, or vitamin B6, can help boost HDL levels as well. So not only does that lower LDL and lowers triglycerides, but it can help boost HDL. It's a little bit challenging. A lot of patients have difficulty taking it because of side effects, but nonetheless, in some motivated patients, it can be a very good medication. Keep in mind, again, our target for LDL is below 100 and preferably below 70 in those with cardiovascular disease, or 30 to 40% reduction from baseline LDL. Triglycerides, it's a good idea to lower these below 150. HDL, our goals are to be above 40 for men and above 50 for women. Again, very challenging. Very few things can do so. Exercise can help, but as far as medication, vitamin B6 seems to be the main player here. So to summarize, statins should be added to pretty much all diabetics, but especially if cardiovascular disease is present regardless of lipid levels, and over 40 years of age and just 1 or more risk factors for cardiovascular disease. Next, monitoring and adherence to hypoglycemic therapy, the medications. It's very important that patient comes in on a regular basis. What we have found is, again, if they're coming in 4 times a year to see you, and maybe even other times just to have touches with your ancillary staff, like a diabetic nurse educator, can be very, very helpful. Reminders, calling them, asking them how they're doing, can also be a very good adjunct in these patients to try to get their parameters to goal. Now, getting vaccinations, I'll talk about this a little bit later, but keep in mind that in this whole aspect of improved outcome, we want to keep in mind that these patients are especially at risk of infections, so we want to make sure we immunize them to influenza and pneumonia. Office posters, I love them. I have posters on diabetes in every single one of my exam rooms. And for the short amount of time that they are waiting for me to come in, they can go over some of the details of diabetes, what it's all about, and remind them about the 5 different areas that diabetes can strike, like stroke, heart attack, kidneys, peripheral vascular areas, and also nerves and neuropathy. So it can be a very good idea for you to have in these exam rooms a nice poster on diabetes. Getting family to be involved, especially valuable to have a spouse, a brother, a sister, a mother. They can be very, very helpful in certain instances to understand what's going on where the patient may not be, or also to help these patients in what's going on in their lives and in their lifestyle, as well as taking the medications and making sure they get the medications from the pharmacy. Management of blood pressure, hypertension. Our patients who are diabetic are especially sensitive to blood pressure, so their parameters are not 140/80, but we want to get their blood pressures to go below 130/80. Now, ACE inhibitors and ARBs are the standard of care, especially if they have proteinuria. But in almost all diabetics who have blood pressure problems, you're going to be using an ACE or an ARB, and oftentimes, more than 90% of the times, you're going to be using a second, even a third medication to get them to that goal of below 130/80. Home blood pressure measurements. Now, we talked earlier about measuring blood sugars at home. Similarly, blood pressure measurements at home can be effective. It's important, though, that you have these patients know how to measure their blood pressures adequately. I usually train them in the office myself and make sure that they take their blood pressures there, and I corroborate it with my own measurement to ensure that there isn't a significant difference. Other important measures to improve outcome. Aspirin therapy. Low-dose aspirin, 75 milligrams to 162 milligrams per day, with essentially all diabetics over 40 or those who have one or more cardiovascular risk factors is a very good idea. Now again, cardiovascular risk factors, family history of cardiovascular disease, hypertension, smoking, hyperlipidemia. It basically means that all diabetics will essentially be on low-dose aspirin. Other medical providers that you want to get involved. Insist that your patients get a yearly eye examination with an optometrist or ophthalmologist. I also ask my patients to see a podiatrist once a year. And finally, as I said earlier, as far as prevention, flu shots. It's very important that your patients know that they're at highest on the list of patients that need to have flu shots. And I mentioned pneumonia vaccination once in a lifetime if over 65, but if you give the pneumonia vaccination between 19 and age 65, a second one is a good idea after the age of 65. Well, thank you for watching this How tutorial on diabetes in racial and ethnic minorities. And please look for other How tutorials on cardiovascularclinician.com and affiliated websites. I'm Dr. Paul Doghramji.